Hey guys, so this video is on electrolyte replacement, and specifically we're going to be talking about potassium and magnesium. These are going to be pretty common things you're going to be doing. So almost every morning, on probably multiple patients, you'll be replacing both of these electrolytes. And so we're going to go over kind of this document I made, and I posted this on the shared Google Drive. You can look at it if you want. And then we'll be going over this and then also kind of in Cerner how to actually put in the orders. And then I have some of these saved as my favorites that you can steal from me as well that are pretty useful. So first off, well, so potassium and magnesium, I would say the most common reason that they're low in the hospital setting is either from using loop diuretics, um, and then just because loops and thiazides, but loops are kind of the biggest culprit. Like in our patient that we've been talking about with the CHF exacerbation, we're pushing a lot of the Lasix, and so that's causing a lot of flushing of potassium and magnesium out. And then another one is like dilutional. So if you're giving a ton of IV fluids, um, generally the especially normal saline, I don't believe has any potassium in it. I think LR has a little bit of potassium in it. And so you're basically diluting kind of their electrolytes. Um, let's see, and then risks and now we'll kind of just focus just on potassium to start with. So the risks are arrhythmias, and then it can cause muscle weakness as a symptom, and then it can also cause a bunch of other things, but those are the two most common ones, or the two main ones. And then this is our hospital's lab reference range. So 3.5 to 5.1 is a normal potassium level. And then some things to keep in mind. So different people are affected differently by like potassium replacement, like exogenous potassium. So if somebody has um, renal impairment, then because potassium is just an electrolyte, so it's flushed out in the kidneys. So if they're not urinating very much, then their kidneys aren't working that well, then they're not going to be excreting as much potassium. So basically, you wouldn't be giving them as much. Some other things prior to like putting in these orders are to check the MAR and make sure another doctor hasn't already put in for the potassium replacement. Because sometimes like your attending might, or the senior resident maybe, might kind of see this before you and then just kind of put in the order. Um, let's see. And then another big thing is if the potassium is low, then always check a mag level, because if magnesium is low, then the kidneys can't hold on to potassium as well as normal. And so they'll be kind of um, like there'll be a lot of urinary potassium wasting. So always check a mag level. I just check it immediately whenever I see that the potassium's low. I put in for like a replacement of potassium and then check the mag level. And specifically, you put that order as an add-on order, so they don't need to do like a redraw of the patient's blood. And then those add-ons a lot of times come back in like 30 minutes, so you can see what it is. Whoops, that one. So next we'll talk about actually replacing it. So I put this in red. This is probably the most important thing to know from this section here is when you're replacing potassium, and this for potassium, it's this works for both IV and oral, but 10 milliequivalents generally raises a person's serum potassium by 0.1. So for example, if their potassium was 3.5 and you give them 10 milliequivalents, in most people, it'll raise it to 3.6. Let's see. And then kind of like we talked about, if their kidneys are in terrible shape, then it might raise it more. Or if they're like really small and frail, it could raise it more. And then so as far as replacement, this is there's different approaches that different people have, but this is one I feel I've I talked with an attending, and then Up to Date kind of also recommends basically this approach. So if the potassium is below 3, then replace that deficit, like anything below 3, with IV potassium, and then replace the remaining deficit simultaneously with oral. And then don't give more than 40 oral at a time. Like at one given time, you can separate the 40 or oral potassium by like an hour, and there's even an order for that. Like you could give at 8 a.m. you could have 40 oral, and then 9 a.m. another 40 if they actually needed that much. But just at any one given time, generally don't give more than 40. Like it probably wouldn't kill the patient, but that's kind of the general guidelines. And then as far as how much to give of the IV potassium, generally infuse at 10 milliequivalents per hour. And so I believe if it's severe, and this is out of the scope of this lecture, but if you have severe hypokalemia less than 2.5, I believe then you can do more aggressive replacement, like up to 20 an hour. That's definitely going to cause burning for the person. Like if you give a lot or even a little bit, some people are more sensitive and it can burn in the veins. But yeah, generally though, don't give, in the orders kind of specify this and everything, generally don't do more than 10 milliequivalents per hour. So let's see. So and we're going to do a couple examples to kind of make this more clear. Let's see. So oral forms of potassium. So there's, I guess, 3, at least that I've seen in Cerner. So there's the extended release tablets. So these are kind of bigger, like horse pill like tablets. And then there's this one. It's the order is called tab-EFF. That stands for effervescent. So an effervescent tablet is like, think Alka-Seltzer tablets. You drop them in water and then it fizzes and dissolves and then turns into a liquid. I've heard that they have a bad taste, but that's an option if somebody can't tolerate swallowing a huge pill. And then there's also potassium bicarb. Generally, we don't use that. I would just use potassium chloride unless you're using it specifically for like acidosis or something, but that's for a completely different lecture. So do potassium chloride. I generally will do just this one, the extended release tablets, but just because all they do is swallow it. You can do the effervescent if they request that, or if you want to. Let's see. I think that was all the points here. So let's go down here. So I guess the next point is kind of showing kind of the ranges. So this is kind of what I saw in my reading. Mild potassium is generally classified as 3.5 to 3, and then moderate is 3 to 2.5, severe is below 2.5. With our hospital system, it's considered a critical lab value if it's 3 or lower. And so then anytime there's a critical value, the lab has to contact the nurse, I believe, and then the nurse will contact you. So you'll probably get a lot of calls about critical values. A potassium of 3 isn't actually that low. I mean, some people could react and have an arrhythmia or be symptomatic, but generally most people are going to have that at like a more severe level. At the same time, though, you need to replace it though if it's 3. So let me see, and then let me pull this up. So, and then this was kind of our cheat sheet here of if it's below this threshold of 3, then you replace with IV potassium. If it's, and then kind of to get it above, you do PO. So let's do a couple examples. So let's say the patient has a potassium of 2.8. So, and it's like 6:30 in the morning. What we're gonna do there is give them 20 milliequivalents because we want to raise it by 0.2. And then at the same time, we're going to order 40 milliequivalents of oral potassium, and they can have all of that at the same time. And there's different approaches to this. If you would like, you could put an order on for more oral potassium like an hour later or later in the day to get them up even higher. Or what you can do is like 4 to 6 hours after, or you would just put the order in at 6:30 in the morning, but you put in a timed study to replace, or sorry, to recheck their potassium like 4 to 6 hours after you replaced it. The oral generally takes about 4 hours to like completely reach the bloodstream. So 6 hours kind of gives you a good buffer of time. And then when that would be what, like noon, or between noon and like 1 p.m. And then you get the lab back, and then if it's still low, then you can replace it even further. So that's one option. And then another option would be to just give them, and you kind of have to use clinical judgment, and kind of see how the patient maybe has responded in the past to potassium, but you could potentially give the IV potassium and then oral at the same time, and then like an hour later give a little bit more oral. And if you feel comfortable, you could just wait till the next morning to recheck. But if the patient is going to have continual loss of potassium, like say you're just loading them all day with a bunch of IV Lasix, then I would probably recheck later in the day just to make sure that it's not low again. And I would generally say if it's below 3, then I would just always recheck it later in the day, just because you want to get out of that critical, like you want to make sure it's not in a critical value, and to confirm that. Let's see. And so that's kind of example number 1. And then the second example we'll do is, let's say it's 7 in the morning, and then the nurse calls you about a critical value of potassium of 3. So since it's 3, we don't necessarily have to give IV potassium. We can just give oral. So what you can do with this, oh, and let's say as a kind of caveat with this one, let's say the day prior the cardiologist saw the patient and recommended, let's say the cardiologist recommended that the patient's potassium be at least 4, like 4 or greater. So with that, let's see, sorry. So let's say the cardiologist recommended that the potassium be 4 or greater. So with that, you need to get it up obviously quite a ways, like an entire point from 3 to 4. So there's a few different ways to do this. What I would probably do is, and one thing, it's not crucial that the patient's potassium get up to 4 in a single day, because you don't want to just tank them with potassium or just dump a bunch on them, because that can be bad too if it just shoots it up super high. So what I would probably do is do 40 oral, and then you can do this in a single order and specify this, and then an hour later give another 40, and then just recheck in the morning. If they're having continual diuresis with like Lasix, and you're thinking the potassium is gonna go even lower, you could recheck later in the day. But that's kind of how I would approach that. Let's see. So I think that's it for, let me see. And then I'll show you some of the orders later. And then what a lot of people like doing is just using the order set. So let me see if I can actually just show you that right now for potassium. He just types this in. There's an order set here. And there's one for magnesium as well. The top part is just kind of a reference information, and then this part up here is for the oral options. So you just say like, hey, I'm in this reference range, and then give that one. And then the one down here is for IV. Yeah, IV potassium, and it's kind of the same. So that's also like a perfectly fine option to do if you don't want to calculate it yourself or whatnot. Let me go back to here. Okay. So now we'll talk about magnesium. This should be a little bit quicker. So some risks of magnesium being too low, neuromuscular hyperexcitability, it can cause like a tremor, convulsions. The patient might feel weak, delirious. It could cause a coma, arrhythmias. And like we talked about, it can cause other electrolytes to be low, like potassium and calcium. This is our hospital's reference range, so it should be at least 1.9. And then this one again it's pretty easy, like the kind of conversion ratio. So, and this ratio is only for IV, whereas potassium it was for IV and oral. So giving one gram of IV mag is going to raise the serum mag level by 0.1. So for example, say the patient has a mag level of 1.9, and then you give 1 gram IV, it should theoretically raise it to 2, like in your average patient. And then the infusion rate, and then so the infusion rate is either, and this is for kind of general replacement. It's not for if it's extremely severe or if you're giving it for another reason. So generally for like the scope of what we're talking about, infuse it at either like 1 to 2 grams per hour. I was talking with an attending because I'd always done 2, and they said they do 1 gram because it's a fairly safe electrolyte. And then it just means the patient's hooked up to the IV for less time. All of the orders though in Cerner are set automatically at 2 grams per hour, so you will have to change that. And I actually let me just quickly show you. So I have a whole order or like an order set favorite thing here. So I actually changed the rate here. So 2 grams in 2 hours. I would recommend stealing this one. It has kind of, I don't have effervescent tablets in here, but otherwise I have kind of everything. So it's like 10, 20, 40 of your oral, or sorry, IV. And then it's got the oral potassium, an add-on mag level. So like everything for me is just right here. It makes it pretty quick to replace these in the morning. And let me go back to the internet. Okay, so yeah, I would recommend increasing the rate, just because say you're giving 4 grams of mag, like let's say they need that and they're being discharged, or even not discharged, but let's say that you're trying to get them out of the hospital and they're being discharged, that would theoretically would take 8 hours if you're doing it 4 grams at 2 grams per hour. So that's like the whole day that they're hooked up to the IV. So yeah, you can do it faster. And then this is out of the scope of this level, but severe hypomagnesemia would be 1 or lower, or if it's symptomatic. And then I would just kind of look on UpToDate of what to do for that, because that's kind of a different topic. Let's see. And then generally, like we pretty much always do IV magnesium, because the oral form, it's a laxative, like think milk with magnesium is a laxative, and then it's just not absorbed very well. Like it stays in your gut and then pulls water or whatnot into the gut. There is a conversion though, if you want to do the oral option. So that's the conversion right there. Let's see. So we did kind of one example. Oh, and then another thing here is kind of similar with potassium, is sometimes the cardiologist will recommend getting the mag level to at least 2, like 2 or greater, to kind of give the heart the best like environment for functioning, just because these electrolytes are like involved in the different pumps or whatever in the heart, the cells of the heart. So I think there's been some studies done, and then patients have like less arrhythmias or go into cardiac arrest. I haven't actually read them, but less than patients who have adequately repleted electrolytes. Let's see. So we'll do one other example. So let's say that the patient has a mag level of 1.5. Then you would do 1.9 minus 1.5 is 4. So they would need 4 grams of IV mag, and then I would do it oral, or sorry, I would do it IV, and then I would do the rate at 1 gram per hour. So it would be a 4-hour drip to get that. Let's see. So I think that covers everything. And then let me go back to this. I'll just show you the order set for this. So if you decide you don't want to do the calculations, then I would recommend calculating it, just because it's kind of fun to do, and it's, like exactly what you're doing. But if you don't want to do that, you can just use the order set here. And then I think that's a perfectly fine option too. And so, all right, I think that's it for this video.